Hello, welcome back in the Hematology Bleep. Today's topic is about um, low platelet count and treatment of um, venous thromboembolism. As a hematology registrar or consultant, you may have received a lot of calls from other departments that my patient has either new DVT or old DVT, new PE or old PE, but the platelet count is on lower side. What to do with the anticoagulation? So anticoagulation, different consultants have different approach. Different trust in UK have different policies. Always follow your trust guidelines and your consultant approach wherever you are working. Um, because sometimes the policies varies and the approach varies as well. So whenever I receive a call from any person that my patient has DVT and the platelet count is hanging around 40 or 50 or 60, what should I do with that? Okay, should I give anticoagulation to the patient, treatment dose, prophylactic dose, intermediate dose, or what to do? I always ask them when was the DVT, okay, and what is the cause of low platelet in this patient. If the DVT is a new DVT, then the first 4 week is an acute period. You need to keep the platelet count above 50 for therapeutic anticoagulation. And if the cause of the low platelet count is treatable, address the cause aggressively. If the patient has infection, address the infection. If the patient has hematinic deficiencies, replace the hematinic deficiency, um, etc. Um, Now, in terms of platelet counts, if the platelet count is less than 50, above 40, and the DVT is new, I will advise please transfuse this patient with a with the with the platelet bag or one pool of platelet to keep the platelet count above 50 because this patient needs therapeutic doses of low molecular weight heparin. So my approach is when the therapeutic doses of low molecular weight heparin is required and the platelet count is on lower side, I always split it. For example, if your hospital is using tinzaparin and patient treatment dose is 16,000 units of tinzaparin only, split it into two, 8,000 morning, 8,000 evening. When I'm confirmed that when I'm sure that the platelet count is above 50 and it is above 50 since many days, yes, um, I can shift that to the treatment dose once daily. If the platelet count is between 30 and 40, I would aggressively treat the cause of the low platelet and transfuse the patient with platelet bag if the DVT is new. But if the platelet count is not rising despite transfusion, then we have no choice to reduce the tinzaparin dose in this patient, which I would say intermediate dose or half dose in the patient, because if I continue to give therapeutic dose to the patient, then the patient can bleed. If the patient platelet count is between 30 and 40, and despite addressing the cause of low platelet and platelet transfusion, the platelet count is not going up, then I will give this patient prophylactic dose. Okay. So the first M is to keep the platelet count above 50 in acute DVT by giving the patient platelet transfusion. But if you have given platelet transfusion each day, now after 3 days, still the platelet count is not increasing, even addressing the cause of low platelet, it means you have to reduce the tinzaparin or low molecular weight heparin dose in this patient. We always use low molecular weight heparin in a patient whose platelet count is low. We do not use warfarin, or we do not use Duoc because there is a risk of bleeding. If the platelet count is less than 30, then mechanical thrombophylacsis only. No anticoagulation is recommended. But you have to try to address the cause of low platelet in the patient and give the patient some platelet transfusions. But if the platelet count does not go above 30, then you have to stop it. So what is the summary of this talk? If the patient platelet count is above 50, you can give therapeutic doses of low molecular weight heparin. Okay, either once daily or you can split it if the patient has high risk of bleeding. If the platelet count is less than 50, above 40, give the patient platelet transfusion to make it above 50 and address the cause of low platelet. Okay, treat infection and address hematinic deficiencies if these are the causes and other causes, etc. If despite platelet transfusion and addressing the cause of low platelet, the patient platelet count is not going above 50, then you have to give intermediate dose, okay, half dose. If your patient platelet count is between 30 and 40, and you have addressed the cause of low platelet count but no effect, you have transfused your patient with platelet units for the first 2-3 days but no rise in platelet count above 40, give the patient prophylactic dose if the DVT is new. If the patient platelet count is less than 30, you have addressed the platelet cause in the patient, but platelet count is not rising. You have transfused the patient with platelet bag, but no rise in the platelet count in this patient, and the DVT is new as well. Then you have to stop the anticoagulation if the platelet count is less than 30. Okay. If if the patient has an old DVT, like a few months back, then you can reduce the dose to prophylaxis as far as the platelet count is above 30. But in new cases of DVT, we always keep the platelet count above 50 if it is possible to give the patient therapeutic dose, because the first 4 weeks is an acute phase of venous thromboembolism and there is a high chances of progression of this clot or appearance of new clot somewhere else or embolization of this clot to somewhere else if we do not properly anticoagulate the patient. That's why we usually anticoagulate the patient therapeutically in first 4 weeks of a new VTE, even by giving platelet transfusion to the patient as well. But the cases where platelet transfusion does not help, then we have to reduce the tenzaparin or low molecular weight heparin dose in the patient. It is always low molecular weight heparin when the patient platelet count is on lower side. We do not give them Duox. If the platelet count is less than 50, we stop warfarin. If the platelet count is less than 50, because there is a high risk of bleeding in this patient. If the patient is on low molecular weight heparin, its half-life is low, small, very small, and you can reverse it by protamine as well. So as I mentioned, every hospital has different guidelines. Every consultant, hemostasis consultant, has a different approach. Uh, Listening to this video is welcome, but when you are addressing your patient, also keep in mind your trust guidelines and your consultant approaches as well. Thank you very much. See you in the next video.